Madam Toya. I hope I'm audible enough. And so just to introduce myself, I'm Gift Chilipo, sonographer working in Namibia. Currently finishing up with my master's in diagnostic ultrasound in Uganda, finishing up my research. Should be doing my defense in a month or two. But I also have a postgraduate diploma in ultrasound that I did in India, bachelor's in radiography that I did in South Africa, and a diploma in radiography that I did in Malawi. So, as was already mentioned, we're going to be discussing about Doppler obstetrics ultrasound. Basically, we'll be focusing about what exactly Doppler studies do we do. I know most of you, this is a cup of cake, and so it's just a reminder. And why do we do them, and when do we do them? So our focus will be umbilical artery, uterine artery, just a bit of ophthalmic artery, the MCA and Ductus venosus. So umbilical artery, why do we do umbilical artery? As we know, this is especially where there's a risk of fetal growth restriction or poor perinatal outcome, or in staging of twin-to-twin transfusion syndrome in case of monochorionic twins. Of course, for the sake of clinicians, if we have any on the platform, we get to, these studies can be requested in suspected IUGR or previous pregnancies that are with IUGR or in fetal death in utero, if there's decreased fetal movement, if there's oligodromnios, if there's polyhydramnios, or in multifetal pregnancy, as we said, in case of TTTS. The maternal conditions that warrant doing Doppler studies, of course, in DM, those that has got chronic renal disease, hypertension, we know that, and thrombotic states. So I'm sure we all know that Doppler indices have been found literally to graduate decline with gestation age, especially the umbilical artery. In this case, that's what we're talking about. So the ST ratio tend to decrease with fetal age. At 20 weeks, it's 50th percentile for the ST ratio is about 4. And then at 30 weeks, it decreased to 2.8. At 40 weeks, the ST ratio decreases at 2.1. And of course, the RI as well, the resistive index, tend to decrease. We're going to discuss a little bit in detail about this in the next slide. Tend to decrease as well with pregnancy, with age rather, from 0.7 to 0.6, 0.5 as the pregnancy tend to increase. And the PI also tend to decrease with age, at least from 1.2, 1.3 to as low as 0.8, thereabout, as the pregnancy is increasing. Okay. So in umbilical artery, increased impedance in the umbilical artery becomes evident only when there's at least 60% of the placental vascular bed that has been obliterated. So for us to appreciate it on ultrasound, then significant obliteration of the placental vascular bed has already occurred. And when that has happened, then it results in marked impairment of oxygen extraction from the intervillous space. And then that explains the FGR, of course. And in those that are developing intrauterine distress, the umbilical artery, then will form usually changes in progressive manner. At the beginning, we have the increased resistance, which is reflected in the reduction of end-diastolic flow. Then the RI values will increase, the PI values will increase, and the ST ratio. And then from the end-diastolic flow, as the spectrum is increasing, then we'll move to absent end-diastolic flow, then we'll move to reversed end-diastolic flow. And so reversed end-diastolic flow in umbilical artery pretty much represents the extreme end of the spectrum. And in UNS, in this group, obviously require admission in NICU and have got a higher risk of cerebral hemorrhage, anemia, and hypoglycemia. Again, just helps us to appreciate when we're doing these scans, to offer some more advice to the clinicians if we have appreciated these things, that, you know what, with what I've found in this patient, then this baby will obviously need a NICU admission. And so necessary arrangements, if we're in a facility that doesn't have a NICU, can be arranged. So umbilical artery flow velocity waveform is primarily determined by placental venous vascular architecture. As I say, increased placental vascular resistance reflected as decreased diastolic phase of the umbilical artery. Absent or reversed end-diastolic velocities during pregnancy, a strong indication of placental insufficiency. When you have that, then we are convinced that there is placental insufficiency. Increased umbilical artery or systolic or diastolic ratio, that's a significant risk factor for progression of fetal acidosis, fetal distress, preterm delivery, and even perinatal death. And when all these occurs prenatally, then we need, because the baby, the mother will obviously need a close follow-up, but also we can advise expeditious delivery in case there is reverse flow, as we said, in a setting that will be able to support the neonate. So diseases that obliterate small muscular arteries in placental artery system villi result in progressive decrease in end-diastolic flow in the umbilical artery, just the pathophysiology of what happens. And then the Doppler waveform will go into absent, then reversal at the end of the spectrum, as we already said. A study of at least 12 randomized controlled trials on Doppler sonography of the umbilical artery in high-risk pregnancies reported that clinical action guided by Doppler sonography reduced the odds of perinatal death by 38%. It just signifies the importance of doing these Doppler studies, especially in high-risk pregnancies. It's got the potential of improving the service delivery. It's got the potential of saving the innocent babies. And of course, in the same study, it also reported that there was a significant reduction in the number of antenatal admissions, significant reduction in the number of induction of labor, number of mothers that required C-section for fetal distress. All these, as we said, just helps us to see how vital as sonographers we are in the cog of helping to give good service delivery. So this is what we're pretty much talking about. I'm sure, as I said, this should be a cup of cake to most of you. It's just a reminder, the progression of the spectrum. This is a normal wave pattern of the umbilical artery. We can appreciate the end-diastolic flow, just a normal low resistance wave pattern. As the disease is beginning, then we have the decrease in end-diastolic flow. So obviously we'll have high resistive indices, high positivity index. The disease is progressing, then we have absent end-diastolic flow, obviously high RI, high PI. When we reach this stage, this is where we talk about advising the clinicians that this baby then pretty much will need NICU when it's born. They should consider delivery when we have a reversal flow of the end-diastolic flow. At this end, this is the end of the spectrum when it comes to imaging of the umbilical artery. Okay, we talked about already this, that umbilical artery imaging really is just, we'll only be able to appreciate it when a large amount of placental venous arteries are obliterated. 60 to 70% has to be obliterated for us to appreciate it. So again, it just tells us that we get to find it at the very end of the disease. But the importance of this is that though it might have to be up to 70% or 60% of the placental venous arteries to be obliterated, we can appreciate it on ultrasound way before the heart rate changes started manifesting. So clinically, they might not be able to pick it up still, but we'll be able to appreciate it on ultrasound before the non-stress testing. Again, just emphasizing the importance of these studies, especially in high-risk pregnancies. So that's pretty much for umbilical artery. But then we mentioned that again that umbilical artery is also important in twins when it comes to twin-to-twin transfusion syndrome. And this is because in monoclonic twin pregnancies, there is a chance that the placenta vasculature of the two babies might anastomose and allow the communication of the two fetal placenta secretions. And in about 25% of these pregnancies, there is an imbalance in net flow of blood across the placenta vasculature from one fetus, which becomes a donor, to the other fetus, which becomes a recipient. And that's basically TTTS. So in about half of these cases, where there is severe TTTS, we will have acute hydramnios in the second trimester. But then, as we said, then there will be flow of blood from the donor to the recipient. In this case, then, when we do our umbilical Dopplers, what we'll find in the donor is that there will be absent or reversed end-diastolic flow in the umbilical artery. And these features are commonly seen in hypoxemic fetuses in pregnancies where there is severe intraplacental insufficiency. So in the donor, the recipient might be normal Doppler, umbilical Doppler study, but in the donor, we have absent or reversed end-diastolic flow. So that's just an example. Twin A, pretty much a recipient. Twin B, a donor that has got reversed end-diastolic flow. Let's try to move. That's just a little bit the umbilical. We can move to the uterine artery. We know that when it comes to uterine artery Doppler, in the first trimester, screening is pretty much for early onset of PE, and of course other adverse pregnancy outcomes such as FGR, particularly early onset of the disease. We know there's early FGR, which is now has been with the expert opinions, they say from at least the FGR that is diagnosed before 32 weeks. That's termed as early FGR. So the first trimester screening of uterine artery can also help us in predicting the possibility of that, the possibility of preeclampsia as well. And in the second and third trimesters, we do uterine arteries just to evaluate pregnancies that are already complicated by FGR. Why do we do uterine artery? What's the pathophysiology? Why is it important to us as sonographers? We want to remember that in the non-pregnant state, the wave form in the uterine artery is a high resistance with low diastolic flow. And there is early diastolic notching in a non-pregnant woman. But then when a woman has gotten pregnant, obviously the needs of the uterus will have to increase. So there is a remodeling of the uterine artery branches just to allow successful presentation. And so remodeling is indicated now by the change of the waveform from a low resistance waveform pattern from a high resistance waveform pattern to a low resistance, because now there will be an increase of blood that is needed in the uterus. And so obviously there will be an increase in diastolic flow. So as we say, pregnancy is associated with physiological changes at the level of the uterine vasculature, resulting in progressive decrease in impedance with advancing gestation. So this maternal adaptation to pregnancy is thought to result from the trophoblastic inversion of the maternal spiral arteries in the first half of the pregnancy. The inverted maternal spiral arteries are then rendered maximally dilated and minimally responsive to the sympathetic and parasympathetic systems. That just explains why there is a change of a high resistance waveform pattern in non-pregnant to a low resistance waveform pattern in the pregnant women. It's these changes, these adaptations in the uterine artery that ensures a sustained increase of blood flow to the uterus during pregnancy. So where we have a problem in the uterine arteries is where there's a lack of physiological transformation of these uterine arteries, where there's a lack of adaptation from high to low resistance vessels. And this is thought to reflect inadequate trophoblastic invasion of the spiral arteries. So in this case, then, the high resistance circulation continues. And of course, then that results in inadequate perfusion of the uterus. So the persistence of high uterine artery PI is associated with placental insufficiency and maternal vascular malperfusion of the placenta. This is where the uterine artery becomes important to us as sonographers, just trying to come up with the pathophysiology of that. In pregnancies complicated by PE or intrauterine growth restriction, impedance to flow in the uterine artery will be increased. So basically, instead of it being a low resistance well-formed pattern, it becomes a high resistance well-formed pattern. That literature tells us that the adaptation of the uterine artery is failed. Another thing is, we talked about that in a non-pregnant woman, the uterine artery, apart from being a low resistance, a high resistance well-formed pattern, it also has a notching. And so when the woman is now pregnant, we all know, I'm sure, that then the notching has to disappear. This has to disappear by 13 weeks, 14 weeks. And the low resistance well-formed pattern should be established by 20 weeks at the latest. So when we do our scan post 13 weeks or post 14 weeks and they still persistent notching, then it should be a worry to us. Though recent studies have shown a low specificity when it comes to notching predicting PE, we're going to come more close about that. But ideally, we shouldn't find notching in the uterine artery, at least post 13 weeks when we scan. If we find that, then that's a predictor of PE. Again, this low resistance well-formed pattern should be established at least by 20 weeks when we scan the uterine arteries. If we continue to find a high resistance well-formed pattern after 20 weeks, then that signals a problem to us. That's, I'm sure pretty much most of us here appreciate what we're saying. That's a proper low resistance well-formed pattern. We can appreciate the systolic peak, the diastolic peak, and then the notching here. As we said, when we scan the uterine arteries, we don't want to see this post 13 weeks, post 14 weeks. This has to disappear. Progressively increasing PI in the uterine artery corresponds to progressive reduction in the placental surface area available for gas and nutrient exchange and increased fetal afterload resistance. And then associated with placental vascular insufficiency reflected by absent, and in very end stage phase, you get to have reversed end diastolic flow in the uterine arteries as well. I think we already talked about this, the presence of notch in the well form and an increase in impedance after 22 weeks of gestation then tells us as sonographers that this is an abnormal uterine circulation, and as we say, it's a predictor of P and of course a potential IGR as well. I think this is just a summary that we talked about. This is very normal. If we found this waveform pattern, which is a high resistance waveform pattern with early diastolic nodes, non-pregnant woman uterine arteries will appear like that. In the first trimester, it will appear like that. That's very normal. By 13 weeks, it will still appear like that. But as the pregnancy now progresses to second trimester, then we expect the notching to disappear. Then we expect an increase in end diastolic flow because the perfusion to the uterus has to increase. We expect pattern. Okay, that was about uterine artery. I'm just going to mention a little bit about ophthalmic artery, which again, it's come into full force recently. Few studies have focused about the importance of ophthalmic artery when it comes to predicting mothers that have got potential of developing preeclampsia or gestation hypertension. So basically, I need, we're interested in the systolic velocity, a little bit of background noise.
Sorry about that, Mr. Chilipo. I think you can proceed.
Okay, thanks. So basically, the values of importance in ophthalmic artery is the first peak of systolic velocity, which in this one clearly labeled the first systolic peak, the second systolic peak, and the end systolic peak. And of course, the ratio between the first systolic peak and the second systolic peak. Again, studies have shown that in a potential women that were going to develop PE, then the first systolic peak tend to be high, the velocity tend to be high, and the ratio between first to second systolic peak also tend to be high as well. Normally, in normal subjects, then the first peak should be about 28, 25 PSVs. The normal PIs should be about 1.3, 1.2 thereabout. So, as we were saying before, the development of PE and gestational hypertension, PI is reduced and the second peak of systolic velocity is increased. The first peak of systolic velocity is also significantly raised in gestation hypertension. So gestation hypertension will only pick that up with the first peak of the systolic velocity that will be significantly increased. But when it comes to the PE, PE then tend to affect both the first peak of systolic velocity and the second peak of systolic velocity, and the PSV ratio between the first and the second peak also tend to be increased. Okay, we can move quickly to the MCA. As we know, the MCA is a high impedance situation with continuous forward flow throughout the cardiac cycle. But then in hypoxic fetus, the central redistribution of the blood flow occurs. I'm sure we all know that, resulting in an increased blood flow to the brain, to the heart and to the adrenals. And progressive fall in the impedance precedes the onset of the late fetal heart decelerations. Again, just underscoring the importance of these Doppler studies, because the clinical aspect of fetal hypoxia tend to develop very late, while with Doppler ultrasound studies, then we are able to pick that up before it reaches the severe stages. So fetal Doppler ultrasound of the MCA is used in two situations. One, an invasive assessment of the fetal anemia. Second, in the calculation of cerebral placental ratio as a measure of fetal brain sparing. And we're going to talk about CPR a little bit in the next few slides, because again, this is a new finding, not really new, it's been used for some years now, but it's been found as well to be more having high specificity when it comes to predicting possible catastrophic ends to the baby compared to individual Doppler indices. So assessment of fetal anemia by using Doppler ultrasound of the middle cerebral artery can start as early as 18 weeks. And secretion of the cerebral placental ratio, the PI is preferred over the ST ratio, obviously for specific reasons that we know. In normal circumstances, flow in the MCA is fairly high resistance, and flow in the umbilical artery is low resistance. We all know that. We've already talked about that. And as a rule of thumb, the ST ratio in the umbilical artery should always be lower than the ST ratio in the mid-cerebral artery. When we do our complete study, compare the ST ratio in the umbilical, ST ratio in the MCA. If the one in the umbilical artery is higher than the MCA, then we're having problems there as well. So in response to hypoxia, the fetus diverts blood flow to the brain in brain sparing, which we all pretty much know, thus increasing the flow of blood that is going to the brain, increasing the middle cerebral artery diastolic flow. Because there's an increase in the diastolic flow, there's a decrease in the PI, and it alters the ratio of the umbilical artery flow to the mid-cerebral artery flow. That explains now the high end-diastolic flow that we tend to find in these hypoxic babies in the MCA. So in the hypoxic group, due to the impaired placental perfusion, the PI in the umbilical artery is increased. In the fetal MCA, PI will be decreased. The ratio in PI between the umbilical artery and mid-cerebral artery will also be increased. This is what we're calling CPR, the ratio between the PI of the umbilical and of the MCA. I think the next slide should be talking about that. Okay. Just a little bit about fetal anemia. In fetal anemia, flow in the cerebral artery increases for several reasons. Just some pathophysiology of it. We all know fluid tend to move faster through a fixed diameter tube as viscosity decreases. That's back to our physics. Therefore, as the fetal hematocrit reading decreases, then MCA flow velocity will obviously increase. And in addition, in a compromised fetus, there is cerebral vasodilation, and this diverts blood flow to the brain. Because flow velocity in the pipe is proportional to the fourth power of the radius, again, your physics, then a small increase in the MCA diameter will result in a considerable increase in flow velocity. That explains why we tend to find these compromised MCAs in anemic babies. We mentioned about CPR, that's comparing the umbilical artery PI to the MCA PI. As we say, this is emerged as an important predictor of adverse pregnancy outcome of late. It has gotten implications for the assessment of well-being in fetuses that are diagnosed as small for gestation age, and those appropriate for gestation age close to term. As we say, it is calculated by dividing the MCA PI to the umbilical artery PI. CPR could be used to assess the risk of interpartum fetal distress requiring cesarean delivery or acidemia at birth and in AGA. So apart from just relying on umbilical artery alone, when we are dealing with babies that have got, that are suspecting of IEGR, then we will do well to combine, to do the umbilical artery and then do the MCA and then compute the CPR, because the CPR has got high specificity compared to the umbilical artery used alone or the MCA used alone. It talks about in late onset SGA, when an abnormal CPR is present, there is significantly higher rate of fetal distress in labor requiring emergency delivery. And again, fetuses that has got abnormal CPR have got a higher ratio of NICU admissions as well. And why is it important? Just emphasizing why we shouldn't just rely on umbilical Doppler alone, but we should move more to CPR, because in most of the cases, when it's in early stages, we can do the Dopplers, and the umbilical arteries will give us normal PI, normal RI, and normal ST ratio. Only when we do the combined CPR, then we're going to be able to find that there is a problem. So it is imperative, really, as sonographers, that we tend to adapt to this need as we continue to help our service deliveries. So in addition to predicting adverse fetal and neonatal outcome, an abnormal CPR is a better predictor of adverse outcome than biophysical profile, suggesting that CPR changes tend to occur well before the deterioration of biophysical profile. And the abnormal CPR might be a powerful identifier for adverse pre- and postnatal outcomes in fetuses with early onset SGA, and should be included as part of the prenatal ultrasound evaluation. That's the guideline from ISAC. Okay, lastly, I think we can talk about ductus venosus. This plays a central role in the return of venous blood from the placenta. We all know that. We tend to run this in the first trimester for screening of chromosomal issues and for congenital heart diseases. And in the second and third trimesters, ductus venosus Doppler study is used to assess the cardiac strain. So in normal circumstances, approximately 30% of the incoming placenta retained, we know it bypasses the liver in the second trimester. But then this percentage has to drop to about 18% by 31, 32 weeks until full term. When placenta function is impaired, then there's a larger percentage of umbilical vein blood flow that is shunted to the left side of the heart, misreading the liver. This shunting tends to decrease flow to the liver, thus impairing liver growth and limited fetal weight gain. That explains the changes in the ductus venosus. So increased placental resistance and peripheral vasoconstriction cause an increase in the right ventricular afterload, and thus ventricular end diastolic pressures tend to increase. And these alterations in the ductus venosus flow velocity waveform, especially absent or reversed airwave, are caused by progressive dilatation of the ductus venosus isthmus in order to increase the blood flow toward the heart in an attempt to compensate for the extreme oxygen deprivation. So reversal airwave is always abnormal. We don't think there's just a picture in which we know that. We want to see the airwave, which is just above the baseline. If we don't find anything here, then obviously we know that we're dealing with an abnormal baby. And associations include, as we said, if there is reverse airwave, then we might be dealing with a baby that have got chromosomal issues or that has got cardiac disease. In twins, reverse of the airwave is a marker for increased risk of developing TTS. If we're doing that in the first trimester and we found that there's reverse airwave in twins, then that's just a potential marker of TTS. And in the second trimester, absent or reversed airwave in the ductus venosus has got a strong correlation with stillbirth. So in the second trimester, third trimester, if you're doing a ductus venosus and there's absent airwave, obviously we know we'll have to advise the clinicians to expedite delivery. And in particular, when a reversed airwave is depicted in fetus with fetal growth restriction, this finding seems to indicate that fetal survival is unlikely beyond 1 week. I've got two case studies, but of course I only share with one. There was a time where I did a scan on a pregnant mother that she was at 32 weeks at that time, and there was absent reverse flow in the umbilical artery, and then went to the ductus venosus. There was a reversed airwave rather. And so communicated this to the referring obstetrician. But at that time, then they had to expedite delivery. They had to do an emergency C-section. But then at this time, both theater rooms in our hospital were all preoccupied. So the mother literally had to wait for 3 hours while they were securing a room in theater. And 3 hours later, when they went into theater, they found that the baby had already died. And it was an issue that, no, you lied, you told us the baby which had already died. But good enough, there were images on the ultrasound machine which proved that the baby was alive, but all these things had already happened. Just trying to emphasize how urgent when you find a reversed airwave at least in the late trimesters and in the setting of FGR to promptly communicate the findings to the referring clinicians. Okay. This is a case presentation about just a preeclampsia case. This is a 33-year-old female, gravida 2 Pala 1, presented with history of gestation hypertension in this pregnancy. But then the previous pregnancy, this patient had to deliver through C-section at 35 weeks because of PE as well. When she came to our clinic for the scan, by RMP, she was 30 weeks. Did the scan. As you can see, the PI in the umbilical artery is about 1.2, which pretty much was the most way normal, but then the resistive index is about 0.7, which is really on the higher end, if you think about it. ST ratio about 3.6. MCA was pretty much fine. And so went to the uterine arteries. this was at 27 weeks, but we still find a diastolic notch, and it showed a high resistive spectral pattern. It had high RI, it had high PI, but at this particular time, our CPR was normal, about 1.5. Though the RMP was 30 weeks, the ultrasound showed 27 weeks. So already an indication that there is potential of early fetal growth restriction here. But because there was notching, then we recommended that we should do weekly serial scans because there was notching, because there was the PI was high. Then the patient came back 2 weeks later. Now the gestation hypertension had progressed to preeclampsia. At this particular time, notching was still present, bilateral in both uterine arteries. You forgive my erasing here. My seniors will not be happy if they see that erasing image. Both showed high resistive spectral pattern. The PI were all high. In the right uterine artery, it was about 2.1. As I say, the normal should be at least 1.3 down. But right uterine artery PI was about 2.1. Left uterine artery PI was 3.5. As we can see in the images, notching was still present late in the second trimester. I went to umbilical. There was no end-diastolic flow in the umbilical artery. MCA was borderline. But now our CPR was abnormal and there was severe oligohydramnios. Ultrasound still gave us 27 weeks, while by RNP, this woman should be 32 weeks. And so already we know that she is in P and we are dealing with a growth retard baby, of course. And so we had to advise delivery to be expedited because of obviously severe oligohydramnios and abnormal CPR, which we said is an indicator of catastrophic outcome. And so we had to advise expedited delivery, and they had to admit the baby in NICU. Unfortunately, the baby could not make it out of NICU. But again, that's just helping us to appreciate the value that we can play with a Doppler ultrasound study. Of interest in this case presentation that I presented is this patient only came to us at 27 weeks when she's had so many scans previously with the GPs at our practice. But then obviously they'll just, despite the history of previous PE in the first pregnancy, obviously Doppler studies were not done in the first trimester scan. Obviously, if they were done, then they should have been able to predict all these things, and necessary measures would have been implemented to avoid the catastrophic outcome that we just talked about, that the baby could not make out of NICU. And these are the things that we want to contribute to the practice. These are the things that we want to change the practice. So in summary, the take home, first trimester, one focuses on detection of aneuploidy and an increased risk for congenital heart disease when it comes to ductus venosus. In the first trimester, of course, when we do the uterine arteries, and of course, with recent research, the ophthalmic arteries between 11 to 13 weeks, we can be able to also help pick out mothers that are going to develop PE or gestational hypertension. Second and third trimester Doppler studies focuses really in growth retardation fetuses, PE, and assessment of TTS using all those vessels that we talked about. And of course, non-invasive detection of fetal anemia when we go to the MCA. In the setting of fetal growth restriction, the guidelines of the Society for Maternal Fetal Medicine recommends weekly Doppler ultrasound study of the umbilical artery, where we've done the study in FGR, we want to recommend weekly Doppler ultrasound study of the umbilical artery. When absent end-diastolic flow or reversed end-diastolic flow is present, Doppler ultrasound study is performed 2 to 3 times per week just to monitor this baby. But we want to know that Doppler ultrasound examinations of the fetal placenta circulation have no role in screening low-risk pregnancies. As much as we might love to do them a lot, but the guidelines say that really these are more important when it comes to high-risk pregnancies. Okay, thank you. This moment in here.
Thank you so much, Mr. Gift Chilipo, for that wonderful presentation. So we realize that there's actually a lot we can do with ultrasound to try and save the babies. So right about now, we'll open the floor. If you have a question, a contribution,